Good morning, everybody. I'm Dr. Mike Sagg from the University of Alabama at Birmingham. Welcome back to day 2 of the 2020 Ryan White Clinical Conference. I'm very pleased to be co-chairing this meeting with Dr. Michelle Iandorio from the University of New Mexico and with Dr. Laura Cheever from the HIV/AIDS Bureau of HHS. And for those of you who are with us yesterday, which I believe is almost all of you, it was a fantastic day and really worked well. We're all disappointed in the fact that we're virtual and not face-to-face. The comments that you all gave us yesterday were fabulous. I think all of us were impressed with the speed with which you did your evaluations. Please keep that up today. And the comments were very, very helpful. And what I think we all were saying was that we love being together in person where we can network in the hallways and chat in between the meetings. But as I'll speak about in a minute, there is a chat function on the presentation mode that you can find friends or colleagues and make comments or make snide remarks about the speakers if you want to. That's sort of allowed as well. So yesterday we went through new data by Dr. Gulick and a cure update by Dr. Janet Silicano. Dr. Benson talked about new drugs and formulations, and then we had a panel discussion on ARV strategies. The breakouts went very well. There was a lot of great comments. Some of the things that we heard from yesterday, I just want to mention that it is true you have to be pre-registered to get into the breakouts, and that's because of size of the room or the Zoom room, or we call it a Zroom, to get in there. So that's the reason, and I apologize to those of you who weren't able to register, pre-register. Hopefully you can get that fixed today. Today's talks are on comorbidities in older adults, HIV-related complications, what's going on with the liver, and then a case panel discussion on implementing PrEP that it will be quite lively, led by Dr. Landovitz. And then, of course, we also have the Meet the Experts breakout during that gap time between the morning and afternoon. And, of course, I realize those are relative terms based on where you're viewing. As we discussed yesterday, the course is approved for 14 CME credits via the IAS-USA, who is a ACCME sponsor for this event. There's ABIM maintenance and certification points, and of course, nursing contact hours, AAFP credits, hours of pharmacotherapy credit, and also pharmacy contact hours. So I think we've got the gamut covered for everybody who's participating. I mentioned this, but the chat features do allow at least some degree of virtual networking. I know it's kind of weak, but at least in terms of being face-to-face versus being face-to-face, but you at least have that opportunity. The platform is interactive and allows us to access things. One of the other comments we got yesterday was that sometimes the speakers would fly through their disclosure slides that wasn't meant to be sleight of hand. The assumption for the speakers was that that there's faculty button on your screen, and you can look up any of the disclosures that any of the speakers have at your leisure. But apologies if that went too fast. I think the speakers just were mindful of staying on time and didn't want to dwell too long on that particular slide. If you see something you like, tweet it. If you see something you don't like, don't tweet it. That would be, and put it on Facebook as well. We're real happy to be partnering with the AETCs, and in particular the NCRC out of New Jersey, who have been our partners in organizing this meeting. They are, the whole AETC network is just a fantastic resource for all providers who take care of patients with HIV, and in particular those of us who are in the Ryan White, I'll call it family, the network that we all work together on and share. And you can see there are AETCs throughout the country, including one in New Mexico. Imagine that, Dr. Iandorio. So let's go to a couple of audience response questions, and then we'll get into today's program. So this one's straightforward. How much of yesterday's program did you attend? Let's go ahead and vote. Okay, let's see what the survey says. I'll Richard Dawson. So most all of you attended all of it. And those who didn't attend all of it attended most of it. So that's great. And for those honest folks at the bottom who slept through it, it's okay. We'll take the place of Ambien in your future. Let me see if I can clear my screen here and get to the next slide. Okay. I need the feature of the, there we go. Thank you. So the next question is, please rate your level of experience as a medical expert. We did this yesterday, but it's what we call an anchor question that helps us know what's what and balance out. I think since most of you were here yesterday, it's got to be the same. And we had a pretty good spread among all the folks, including a fair number who have been doing this for a long time and really are pretty expert at all this. So let's see what the survey says. And again, I think it looks pretty much like yesterday, although I think folks, even just from yesterday, have rated themselves a little bit more expert. So I guess I'll take that as a compliment for the meeting. Okay, and let's remove that and go back to this. And how would you classify your work setting? Are you urban, rural, or suburban? Go ahead and vote. Whoops. Okay, we can see what the survey says here. And it looks like most people are working in a city sort of environment. That's great. But a fair number, 22%, almost a quarter of us are working rural. Let's, and then we'll move on to, I need to reshare my screen, sorry. And that's it for the intro. Now it's time for me, with great pleasure, to introduce our first speaker this morning, Dr. Melanie Thompson. Dr. Thompson works out of Atlanta. She founded a clinical trials group way back in the late 80s and has been heavily involved in that with testing some of the original drugs for treatment of HIV and a lot of its complications. She is a frontline provider, but has also been a huge advocate in policy, both locally in Georgia, but also throughout the country. Today, she's going to talk to us about an emerging issue, which is aging, which is good. When we founded our clinic in Birmingham, our motto was birthdays are our business, because the more people who had birthdays, the older they were getting, and we were having success. So it's my pleasure now to turn the podium over to Dr. Thompson, who's going to talk to us about comorbid conditions, especially as people are aging. Dr. Thompson, welcome.
Thank you, Mike. I am going to try to share my screen here. We'll see. How are we doing? Oops. Is my screen shared?
Yep.
Okay, awesome. So this is the financial disclosure slide that I am going to go through quickly, but you can look it up. I do a lot of clinical trials. And here are a few learning objectives. having to do with risk for cardiovascular disease, diabetes, and frailty. So really one of the triumphs of all of medicine in the 20th century is the development of antiretroviral drugs that has allowed people with HIV to live a near normal lifespan. And even though there are disparities according to race, ethnicity, age, gender identity, and use of injection drugs, all groups have really made progress over time. And the problem, of course, for the 21st century is that older people accumulate multi-morbidities. And so it turns out that people with HIV tend to have more comorbidities at a given age than people without HIV. And you can see that for people with HIV, almost 70% have 2 or more comorbidities. But this isn't just in the over 65 group. Even in the 50s, people with HIV have more comorbidities. A person dear to me in his 80s was very fond of saying that aging is being nibbled to death by goldfish. And if that's true in your 80s, imagine how much it impacts people in their 50s with HIV when the nibbling begins. So today we're going to touch on some of these considerations for aging with HIV, particularly the ones in red. But here at the beginning, I want to lift up the idea that stigma impacts people throughout the lifespan, and stigma about HIV, gender identity, sexual orientation, as well as race, ethnicity, is particularly impactful for older adults whose social networks have diminished. Likewise, older adults especially feel the impact of social determinants of health, creating financial, housing, food insecurity, and so on. So let's turn to cardiovascular disease, the most common comorbidity. People with HIV contribute substantially to the global burden of cardiovascular disease. Up to 1/4 of people in sub-Saharan Africa with HIV have cardiovascular disease. And there are important risks for people living with HIV for cardiovascular disease, including a CD4 count less than 200, or presence of hepatitis C. But really, the risk factors for MI in people living with HIV are the same risk factors as for the general population: smoking, elevated cholesterol, hypertension. And if you look at how common these conditions are, they are the most common age-associated conditions among people living with HIV on therapy. So cardiovascular disease is more common in people living with HIV. Myocardial infarction, heart failure, stroke are up to 2 times higher for people with HIV than those without HIV. But also we see higher rates of pulmonary hypertension, blood clots, and sudden death. Now, this is an important American Heart Association statement, and I hope you will go to the website, download it, and use this to refer to as you treat people with HIV and cardiovascular disease. They recognize the increased risk of heart disease in persons living with HIV, and they address the pathophysiology, which I am not going to address today, but also focus on screening and treatment. And it includes a link to a patient perspective by Jules Levin, who was one of our foremost advocates for older people with HIV. So here is the screening and treatment algorithm. They use 2 approaches, a high risk and a low to moderate risk approach. And I know you can't read this, but I'm going to help you drill down on it. So let's start with the high risk approach. So this applies to people who have known atherosclerotic cardiovascular disease or a high LDL of 190 or more untreated, or people with diabetes ages 40 to 75. But you can get to this high risk bucket by being in the low risk bucket and having a high risk score according to risk calculator tools. or because of presence of risk enhancers. And we're going to come back to that in a minute. So for these at high risk, the cardiologists want you to consider a cardiology referral, of course, after the risk-benefit discussion has taken place with the patient. It's really important to discuss lifestyle optimization, both for high risk and for lower risk people, and particularly smoking cessation. And you're going to hear that a lot from me today. It's one of the most important things we can do. High-risk individuals should be started on lipid-lowering therapy using the start low, go slow approach. So if there are toxicities, we decrease the dose or we stop if they are severe. The recommended statins are atorvastatin, rosuvastatin, and pitavastatin. And I would just bring to your attention that pitavastatin was actually tested in people with HIV. It was found to be superior to pravastatin, which is a low-intensity statin. But notably, both of these drugs have few drug-drug interactions and have no glucose effect. I also want to remind us that simvastatin and lovastatin are contraindicated with protease inhibitors or cobicistat. And when we meet with statin toxicity or an insufficient response, now's the time to consider adding additional drugs. So moving to the low moderate risk approach, this is when the calculators come into play. So we know that a 10-year risk of greater than or equal to 7.5% confers high risk for cardiovascular disease, but also other models such as the DAD model and the Framingham model can be used for risk calculators. But here's just a cautionary word about all of these risk calculators. The traditional risk assessment tools, all of these, may underestimate the risk in people with HIV by up to 2-fold. And this is especially true in the setting of prolonged viremia, such as with delayed ART initiation or treatment failure or non-adherence, for people who have a lower CD4 count, less than 350, or for those with metabolic syndrome or hepatitis C. So this is where the art of treatment comes in, because we really don't have exact guidelines for people with HIV. But the traditional risk enhancers also elevate the risk of people with HIV, including family history of early MI or stroke, elevated LDL above 160, kidney disease, subclinical atherosclerosis as determined by coronary artery calcium greater than 100, and then some biomarkers if you happen to have them. So also, we just need to remember that there are things other than lipids. We need to control other risk factors such as smoking. It's very, very important to intervene with this. Diabetes increases the risk of MI substantially. Hypertension is very prevalent, and so is obesity. And as we deal with patients who need to lose weight, we encourage exercise, but remember, they need education often about diet. It's not a no-brainer, so please provide education. What about aspirin? Well, it has not really been studied in people living with HIV. What is being studied is whether a statin can decrease risk in people without hyperlipidemia, but we're going to have to wait for the results of the REPRIEVE trial to get that answer. Now, diabetes is treated the same way in people with HIV as with those without HIV, but there's a little trick in terms of diagnosis. So the American Diabetes Association has verified that there is an altered relationship between hemoglobin A1C and plasma glycemia for people with HIV who are on antiretroviral therapy. And therefore, for those people, we can't use hemoglobin A1C to diagnose diabetes, and we have to fall back on the plasma blood glucose criteria. And here are those data showing the discordance between hemoglobin A1C in people on antiretroviral therapy compared to controls. And as you can see on the right, unfortunately, this varies according to the particular antiretroviral therapy, and there really isn't a fudge factor. It can be overestimated or underestimated. So although you can follow hemoglobin A1C, you really can't use it to diagnose diabetes. Now, I've talked a little about smoking and heart disease, but smoking is a huge risk factor for cancer, and up to 3/4 of our folks with HIV are smokers. We know that smoking is associated with cancer burden 94% in lung cancer, but also other smoking-related cancers such as esophageal and oral cancers are worsened by, the risk is worsened by smoking. And interestingly enough, so is anal cancer by about 32%. Now, hand in hand with comorbidities comes polypharmacy. I've listed a bunch of drug interactions here. You can look at them later. I'm not going to go through them all. But my big point is don't guess about this. Look it up. I look things up almost every day because some of the drug interactions are unpredictable. Even with the antiretrovirals or among antiretrovirals, sometimes we don't know these things, but with a million other drugs out there, we really have to be mindful of drug interactions and look them up. I've listed at the bottom of this slide the Liverpool Drug Interaction Database, which is awesome. So please go there, get familiar with it, and visit frequently. Also, we need to watch for additive toxicities. For example, we don't want to give a bunch of nephrotoxic drugs together. Inappropriate drugs or inappropriate doses are always prescribed by other clinicians, not us. But anyway, we should look at everyone's pharmacy list to be sure that the drugs are appropriate and that the doses are appropriate. There is an increased risk for forgetting doses or forgetting prescriptions when there are lots of pills around. And expense is a huge issue for older people, and I'm not going to get on that soapbox, but I do have one. So let's talk about frailty. Frailty causes bad things: falls, hospital admissions, even mortality. But how do we actually define frailty? Well, I want to go over 3 common tools for assessing frailty, although there are others. So Fried's frailty phenotype, easy to say, consists of 5 physical variables. There is also a short physical performance battery, SPPB, that consists of 3 physical tasks and is easy to do in the office. And then the frailty index is a survey with 40 variables. So we'll briefly go through these, starting with Fried's. So the variables in Fried's phenotype are weight loss, more than 10 pounds or greater than 5% a year, exhaustion, self-reported, low energy expenditure, so being sedentary, a slow gait speed, and weak grip strength. And note that this is the only one that actually measures grip strength, and you have to have a dynamometer, which actually limits the usefulness of this in most practice settings. But this phenotype does predict mortality and also predicts increased mortality for the pre-frail individuals. But it also predicts worsening disability and incident falls and first hospitalizations. And notably, the frailty phenotype was more common in women and African Americans. You may want to remember that point. The SPPB also predicts mortality, more so in people with HIV, as you see with the arrows, than people without HIV. Now, this is a battery of 3 physical tasks: repeated chair stands, so you sit and stand 5 times, a couple of balance tests, and a 4-meter or about 10-foot walk test. So easy to do. The frailty index actually relates these deficit accumulations to the risk of death and disability. There are 40 variables. An example of a physical variable would be walking outside fewer than 3 days a week. So that would be an important one to remember as well. And comorbid diseases actually count in terms of the number of them, but not their severity. So having more comorbid diseases, even if mild, is count as risk. And these are scored between 0 and 1, with the lower score meaning more robust and the higher scores indicating frailty. But remember, frailty is dynamic. It's not always the same, and that means we can intervene to prevent or lessen frailty. So although there are not a lot of data, these are kind of the important things that we should be thinking about for older people. Exercise, strength and balance training, social interaction is very important, as is a healthy diet. Being in preventative healthcare and screening is extremely important. And then we are partners in the management of medication and also in urging smoking cessation. So we'll shift for a second to screening for HIV-associated neurocognitive disorders, which we called HAND. These are 5 screening tools that you may recognize. They all have variable sensitivity and specificity. It turns out the International HIV Dementia Scale, when paired with the Cognitive Assessment Tool, or CAP-RAPID, is a good method for predicting HIV or detecting HIV dementia. However, none of these screeners, alone or together, really had adequate sensitivity and specificity to pick up asymptomatic or mild HAND. So for this, you may need full neuropsych testing. But I just want to call out the things we sometimes forget. When you have someone with a neurocognitive deficit, don't forget the reversible causes: syphilis, thyroid disease, B12 deficiency, depression. So it's important to do your usual dementia workup. Mental health and substance use issues are very common. Screening, unfortunately, is not very common. We as clinicians are terrible at this. But there are easy screening tools that are available and, importantly, reimbursable in some cases. I would call out the depression tools, PHQ-2 and 9. The PHQ-2 question is really very easy to do within a visit. Over the last 2 weeks, how often have you been bothered by the following? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless. And then each of these are scored. So very, very simple. There are also tools for alcohol use and for drug use. And if you are not familiar with the National HIV Curriculum, I invite you to run, not walk, to this site, which is hosted by the University of Washington. And you will find all of these screening tools on the site, as well as many calculators that we commonly use, like for BMI. So I want to end today talking about social isolation. Social isolation is associated with increased mortality. And why is this important, particularly now? Well, I think one of the real tragedies of COVID is not only that older people are more susceptible to poor outcomes, but also that it's been necessary to severely restrict the comings and goings of older people, and really to worsen their social isolation. And so this confers increased risk, and we should be very aware of that. And for people living with HIV, particularly if they're 65 or older, they are much more likely to experience social isolation than those who are HIV negative. So this confers additional risk. These data came from a study that showed that social isolation predicted hospitalization, mortality, and other outcomes in HIV positive older veterans. And this is the score that was used, the social isolation score. And you know, if you look at this, it will become immediately apparent how many of those have really been impacted by COVID. So older people are not having as many visits from family and friends. They're not able to attend self-help or support groups or work with community organizations in person, or even go to religious events. And so I think it really falls on us to explore these issues with our older patients and to help them learn to devise strategies to address social isolation, including using technology. And many are not aware that you can participate in support groups online, or visit community organizations and volunteer with them. My mother-in-law has Mass with the Pope every Sunday morning, and she loves it. So, I think we really, at this time, need to be very aware of social isolation for our elders. So there is no group that needs patient-centered care coordination more than older people living with HIV. So this is really something we should do as much as possible in our clinics. And I want to shout out the HIV/MA primary care guidelines as a reference for you. And importantly, this 2013 update is being updated in 2020. Yay, finally. And we will let all of you know when this update is available, and you will find many of these issues covered in these guidelines. So that is all for me for right now. And I think it's time for a few questions and answers.
Great. Thank you so much, Melanie. Really wonderful, wonderful overview. We're going to have questions coming in right now, but let me start off with a couple things. I couldn't agree more with really everything you said, and especially the notion of the screening run, don't walk to the University of Washington site. We've been using those patient-based outcomes since 2007. And they not only help us get a better picture of what our patients are going through, they also help me on my visit because we screen for symptoms walking in the door. Oh, tell me about this fever. So it really helps make the practice more efficient in a lot of ways. I have another question, but I'm going to go to the questions from the audience here. So yesterday we talked a lot about weight gain, potentially related to antiretroviral therapy, and know the implications of weight gain in terms of lipid profiles and that type of thing. What do you think this weight gain is going to translate into for folks, especially as they get older?
Well, I think that's a great question. And of course, we don't have those data yet. We're just barely getting more comprehensive data about weight gain. But I think what we need to do is really the basics that we would do with anyone who is experiencing weight gain, to be sure that we control their lipids, that we look for glucose intolerance, and screen for cardiovascular disease as needed and as appropriate. So, while we wait for longer term data, I think we just have to assume that people who gain significant amounts of weight and who have high lipids and so on various antiretroviral therapies need to be managed for those conditions. And, we will learn more about whether changing therapies actually makes a difference in some of these people. But I think right now I treat them the same way that I treat other people who have the same characteristics, and just try to be conservative as we sort of walk through this conundrum of weight gain and what to do with it regarding antiretrovirals.
Okay. And speaking of that, one question here on the risk of cardiovascular disease with very high triglycerides. We saw that a lot with ritonavir use back in the day. What are your thoughts about that?
Well, it's interesting because the AHA guidance specifically doesn't call out high triglycerides as a major risk factor for people living with HIV. And that's partially because of the association with antiretroviral therapy. My feeling is that people who have high triglycerides, very high triglycerides, should be evaluated to see whether changing their antiretroviral therapy is appropriate. Certainly ritonavir, cobicistat can cause high triglycerides. And I think we should assume that there is some risk associated with very high triglycerides, even though it's not really called out as a major risk factor by the AHA.
Yeah, I think that's right. Moving on, we have a bunch of questions about hemoglobin A1C and glycemic control on people on ART. How do you use it, or is there a problem using A1C for PrEP? What are your thoughts about that, if it's over or underestimation as a true glycemic burden?
Well, I know the data that I showed and went through very quickly with the different antiretrovirals was probably difficult to see, but tenofovir was one of those antiretrovirals that actually is associated with a discordance. So I would say I would probably not want to use hemoglobin A1C for diagnosis in people who are on a tenofovir containing PrEP regimen. And it does make you want to be aware of that kind of screening in appropriate people before they get started on PrEP. So before they start on drugs, then you can use hemoglobin A1C. I also, sort of looking ahead to another question about hemoglobin A1C, I think you can follow hemoglobin A1C in people who are diabetic, and just recognize that if you change their antiretroviral therapy, it may have an impact on their hemoglobin A1C. But at least following along with the hemoglobin A1C may be helpful in people with diabetes.
Yeah, and there's obviously a similar question here just about the recommendations for metformin. Can you try to nail that down for us if is a type 2 diabetic type picture, when to start it, what to do?
Well, I think in general, diabetes and prediabetes are handled the same for people with HIV than as with people without HIV. But I would call out for metformin one interesting drug interaction that some people are not familiar with, and that is that bictegravir actually increases by about 40% levels of metformin. So metformin is a very useful drug, but if given with bictegravir, I think you should be cautious and particularly look for side effects, because that is how you're most likely to detect toxicity and drug interactions. So GI side effects, diarrhea, and so on.
Yeah. Let's segue over to the isolation, which is a really big challenge for all of us, actually, but especially for folks who are older and maybe living alone. What are the rates of depression, or would you call it depression, or maybe it's demoralization? If we're going to make a distinction between the two, it feels like maybe more demoralization.
Yeah, so I don't know of large studies looking at that. I think there have been smaller studies showing that rates of actual clinical depression have increased during the time of COVID, and not just for older people. It's important to realize that social isolation and loneliness are similar but different. And social isolation is a risk factor for bad things, but it's also important to assess loneliness. And what we see with a lot of people is that they are extremely lonely during this time, and they may or may not be what we would call socially isolated, but the decrease in available contacts really can affect people. And so loneliness also is a real risk factor for bad outcomes. And I think that we have to control the virus. That is what we have to do in order to get all of us out of whatever stages of lockdown we are in. But I think it's really important to develop programs and develop strategies specifically for dealing with depression in our older population and loneliness. And the other thing I would say is it's important to have these conversations with people. You know, I talk to people every day about how they're feeling, and some people who are social introverts are like, "Oh, I'm good with this. You know, it's what I do every day." But the extroverts are really struggling. So, you know, take time to talk to people, and they'll tell you how they feel. And this is also a way that telemedicine can help.
Yeah.
Saying
And just,
telemedicine,
yeah, improving the
it's been awesome,
conversation.
actually. We kind of flipped on a dime to telemedicine, but it's really terrific for some people.
Yeah. Let me introduce this next question with sort of a comment. I think the things you mentioned about assessing frailty, kind of straightforward, I won't say easy, but straightforward things we can do: sit, stand, 10-meter walk, a 4-meter walk, etc. But I don't know many that have incorporated that into their everyday practice. It's just one more thing to do. And if you were going to recommend that, feels like it should be kind of universal, but what age would you start doing that? And for that matter, what about a MOCA, or, you know, we can look at person, man, woman, camera, TV, or something.
Oh, that was good, Mike. You got all 5 of them.
Did I? Okay. But seriously, what do you think? When should we do these?
Well, first of all, I want to plug my breakout session, because we're going to talk about this a lot more and play around with some of these frailty measures. I would say, and the recommendations are to begin around age 50. Now that varies according to people, but you know, we see that people begin to have these frailty characteristics earlier. And what's interesting about doing the tests, for example, the SPPB, which is a physical test, apparently people don't really recognize how frail they are sometimes. People are good at compensating, but when you do these physical tests, sometimes it can bring out frailty that is sort of being downplayed or not so much recognized, that you can really address. So, you know, I think beginning earlier than you might think is appropriate is a good idea. And, you know, this is not something that you do at every single office visit for every single patient, but I think it's important to incorporate it into your workup for these individuals.
Yeah.
It doesn't take that long. And in the breakout session, we're going to go through the SPPB and show exactly how you do it. But I also want to point out that Medicare is looking closely at the frailty measures. And, you know, that is something that we may see come into play in terms of reimbursement someday.
Yeah, and I just, we're going to have to wrap up, I'm afraid, but I do want to reemphasize something that you said that I thought was maybe the most important thing. They had a lot of important things, but that a lot of the frailty is somewhat reversible if you do some training, you get balance strengthening, core strengthening. There's ways to improve that, maybe more than most anything else we can modify. So that's something to keep in mind. We don't just throw our hands in the air and say, oh, well, don't worry about it.
Absolutely.
Yeah, wonderful talk, Melanie. Thank you so much for doing this and for being with us. And we look forward to your breakout session.
Thanks, Mike. Bye, everybody.
Bye.